Hey guys, Dr. Brown with elbow, wrist, and hand therapeutic exercise considerations. One thing you should understand about this area is that occupational therapists have a pretty strong foothold in treating these disorders, particularly when it comes to things that are in the wrists and hands. So we don't see as many of these in physical therapy, although if you're in a more rural area, you're likely to see them. If you're in a larger area, maybe even like El Paso, there are likely to be certified hand therapists out there that do the bulk of this work. However, there are some interesting things, and I hope you enjoy our lecture today. So, modular overview, we're going to look at the overall issues with each area and the themes of those. We'll look at proximal pain generators, joint interdependence, pain generators by area. In other words, those are obviously going to be different depending on if the elbow pain is lateral or medial, for example. And then we'll look at pathology and exercise considerations. So an example of pathology and exercise consideration of shoulder is impingement, rotator cuff, and scapular dysfunction. So we'll look at some of those things with regard to the elbow and the wrist and hand. So the elbow. One important thing to understand is that the elbow joint proper, which is the ulno humeral joint, is quite congruent. In other words, it's a tight joint. Therefore, there's usually not a problem with osteoarthritis in this joint. Joints that tend to have more mobility tend to have more issues with degenerative processes, so that you can kind of take to the bank. Pathology in this area is dominated by tendinopathy. So those issues that favor tendinitis are young adults and true overuse conditions, while tendinosis, which you recall is a degenerative tendon process, tends to affect the middle age, and those with a history of heavy sport or occupational activity that make their tendons be more susceptible to degenerative processes. The interesting thing is that we really can't distinguish between them as far as the exam goes, but as we'll see a little later and discuss, the subjective information could be helpful. Medial and lateral elbow joint problems are more common than anterior-posterior elbow problems. Instability medially is generally due to overuse, and laterally is due to trauma. We won't say much more than that with regard to the elbow. Nerve conditions, generally the ulnar nerve is more consistent or prominent than the radial nerve pathology, and median nerve pathology through the elbow is relatively uncommon. Wrist overview and themes. This is a biomechanically complex joint. We call it an intercalated joint. And what that means is that what happens at that joint is a reflection of what happens above and below. So with an intercalated joint, which the talocrural joint at the ankle is also, there's generally no direct muscle attachment in this area. So if you think about the wrist and the hand, the muscles attach up in the forearm or even up at the elbow and then cross the wrist without ever connecting with those joints. There's only one tendon that attaches on a carpal bone, and that is the flexor carpi ulnaris to the pisiform. The proximal row articulates with the radius more than the ulna, so when we load the wrist closed chain, most of the force is through the radius. The distal row articulates with the metacarpals. Trauma can lead to ligament tear and a cascade of instability, which takes time. But we'll talk about that a little more later. There is the presence of a tenosynovial sheath around the tendons that cross the wrist, with the exception of flexor carpi ulnaris, which is the only one that attaches to a wrist or carpal bone. We need a certain number of degrees to dorsiflexion and palmar flex the wrist in order to function. I think it's around 45 degrees. We'll get that clarified. And ganglion cysts are quite common, but not always symptomatic. So if we find really nothing, but they have a big old bump in their wrist or in their hand, it could be that their symptoms are coming from that. Hand overview. There are proximal effects from a nerve standpoint that can be either radicular or referred. And we'll talk about those distinctions, which is important coming up. Nerve local disorders. Carpal tunnel is clearly the most common in the wrist and hand, which causes obviously carpal tunnel syndrome, and ulnar tunnel syndrome in the palmar side of the hand, on the ulnar side of the hand, is also relatively common. Acquired disorders include trigger finger and Dupuytren's contracture. We're not going to cover those now, but you'll see them in musculoskeletal. The biggest threat to function is tendon rupture or laceration. So folks that have a tendency for tendon rupture are rock climbers, for example, or people obviously work with sharp knives and equipment. And like I said, it's usually an area of specialty for occupational therapy. So elbow and wrist mechanics. The ulnar humeral joint in the open chain is concave on convex. And that should make sense to you. There's a concavity of the proximal ulna, and it goes over the capitellum of the of the humerus. In closed chain is the opposite. So down here you'll see that I'm just going to introduce this to you quickly. Convex surface on concave. When the convex surface is moving on a concave surface, okay, that would be, for example, the glenohumeral joint in open chain. The joint glides in the opposite direction as the motion. So in other words, when we raise our arm overhead, the motion is upward, but the glide is downward in the joint. And that's opposite if it's in closed chain for convex on concave, right? But a concave joint moving on a convex joint, the glide and the motion are the same direction. So the shoulder is pretty easy to kind of visualize, and we'll review that a little bit in class, and that'll make more sense to you. So the proximal radio-ulnar joint, there's an open, in the open chain it's convex. That's the radial head on concave, the fossa on the ulna. Okay, so the distal radial ulnar joint, there's open concave on convex, so it's the opposite. And the wrist in open chain for flexion extension happens at the proximal row, between that proximal row and the radius. And in open chain, that's convex, lunate, and scaphoid on a concave distal radius right here. Okay. All right, so proximal pain generators, referred versus radicular. I want you to understand the difference here. We've talked about it a couple of times already. Radicular symptoms are symptoms that emanate from nerve root irritation or compression. So you're going to have a situation where it's going to go along the entire path of generally of the pathology. So in other words, if we have a C8 nerve root compression causing radicular symptoms, it's going to go all the way from the medial arm, medial forearm, all the way down to the medial or ulnar side of the hand. Where referred pain is spreading from a structure to a different area. So a good example here would be cubital tunnel in the elbow, where the ulnar nerve or funny bone area can become compressed or restricted. And what we get then is we get symptoms from the medial elbow down to the wrist. That's not radicular, it's referred. So radicular, remember that it's a root irritation, where referred pain is from some other somatic structure, such as a joint or a muscle or a tendon or a joint capsule or something of that nature. So understand that the cervical spine, in the cervical spine, the lower discs particularly, like C5-6, C6-7, C7, C8, can refer almost anywhere in the upper extremity. So on occasion, we'll get folks with elbow pain because of the neck, and it's not so obvious. We'll talk about that when we get to the lateral elbow. For shoulder issues, the rotator cuff and bursitis can refer pain down towards the elbow and even beyond. The key here to understand is that the greater the amount of irritation, the greater the distance it travels. So folks with a bursitis in the shoulder may have pain down to the elbow, but maybe a week earlier when it was really hot, they might have had pain down the forearm as well. And as it gets better, it migrates back up towards the shoulder. And then thoracic outlet syndrome occurs between generally the clavicle and the first rib, and that causes mostly ulnar distribution symptoms down in the forearm and the hand. So the key here is that that type of, the most common type of thoracic outlet syndrome causes symptoms at night. So people will wake up with symptoms on the ulnar distribution of the arm and hand. They don't have any sensory changes that are objective. They don't have any weakness. They just have pain. And they get up, shake it out, and it gets better. So hopefully you'll learn more about that in musculoskeletal. Joint interdependence. Just like the hip affects the knee, the shoulder can affect the elbow, and the elbow can be affected by the wrist. So folks with limited posterior glide shoulder internal rotation tend to have an increased medial load at the elbow joint for throwers. This is for people that throw, javelin throwers, water polo players, baseball pitchers, things like that. Additionally, you'll see this in the folks that work with desk work at computers a lot. Folks that have limited wrist dorsiflexion range of motion tend to have increased problems with the lateral joint at the elbow. With tendinopathy, it increases the load on that side to the muscle. So what happens along that chain, just like what happens along the chain in the lower extremity, is important. All right, now we're going to talk about typical pain generators by location. In the lateral elbow, remember, in the elbow, tendon issues dominate. So muscular tendinous is number one, and that would be lateral epicondylopathy, which usually, or I should say essentially 100% of the time, affects the extensor carpi radialis brevis. About 50% of the time, it affects the extensor carpi radialis longus, not as common. So remember, ECRB is the one for lateral elbow. There are also other issues. I call them mimickers because they can sound remarkably the same. Lateral elbow pain. In early stage of nerve disorder, we can have radial tunnel syndrome that causes pain, but in the early stages does not have the motor or sensory component. So we can't rely on weakness or sensory changes to identify a nerve problem. So it's very, very challenging because in the early stages it may only cause pain. For the joint, the radiocapitellar joint, which is the radiohumeral joint. So if you think about the radial head, right, it's round. It's not really a true joint like the radioulnar joint, but it is a joint. And because it's more mobile, it is actually more prevalent to have osteoarthritis or osteoarticular problems at the lateral elbow than the medial elbow. And then ligament issues. Trauma can cause a lateral ulnar collateral ligament tear, which leads to instability, and an annular ligament tear, which causes problems, particularly can be in young children. So just understand, tendon problems are the biggest issue here, but there are mimickers that can make it sound like a tendinopathy when they're really something else. In the medial elbow, same thing. Muscular tenderness first, then probably cubital tunnel. Again, early stage nerve disorders in the elbow can sound essentially the same as a tendon issue. Okay. In later stages, as I said before, you can have referred pain down the arm towards the wrist from compression of the ulnar nerve here. The ulnohumeral joint, well, like I said, it's a congruent joint. It's very tight. Therefore, it usually takes trauma or overuse, like a baseball pitcher, to create a problem there. For ligament issues in the medial elbow, obviously baseball pitchers and their ulnar collateral ligament is the problem. You'll learn a lot more about that in musculoskeletal. So, these again can sound remarkably the same. Throwers can have joint, ligament, and muscle issues all at the same time, including the nerve, by the way. Joint, ligament, muscle, and nerve. Because when you're loading the elbow like you are when you're throwing, all those tissues can be affected. Not so much for the other folks, but the throwers, we need to be especially aware of that. Anterior elbow problems, again, distal biceps tendon. Here we're going to throw in a little bursa issue. In a later slide, I'll show you how to differentiate between those two. Nerve issues in the anterior elbow tend to radiate pain to the forearm and hand, although they're relatively uncommon. But anterior elbow pain does not tend to refer down the arm if it's musculoskeletal tenderness. It's local. And so with the bursa, that would be local. So it's possible to get this sort of thing. We can have vague symptoms in the elbow from the ulnohumeral joint. Again, takes trauma or overuse. And the ligament there, it's important to understand, the ligament anterior capsule tightens with trauma. So if I have an elbow fracture and I'm immobilized, I lose extension of the elbow joint. That's usually how it works. People will often end up with a 5-degree loss of motion in the long run, no matter how good your therapy is. Posterior elbow problems, distal triceps, and bursa. Okay, those are obvious, big bump on the back, and those are usually due to blunt force trauma. Ulnohumeral joint can cause vague symptoms in the posterior elbow, and there's no nerve or ligament issue we need to really worry about back there. The folks I've seen are heavy pushers, in other words, linemen, football, people that push a lot of weights, like weight trainers. They can have triceps tendinopathy. Okay, moving on to the wrist. In the wrist, muscular tendinous problems on the dorsal side are usually because of tenosynovial irritation. So the common extensor tendons of the finger extensors are all surrounded by a tenosynovium, and those tissues can become swollen and irritated, but it's pretty obvious because they'll be swollen there. You can see the swelling. You can also have dorsal wrist pain due to scapholunate dissociation. I'll show you a picture of that later. Or distal radial ulnar joint disruption from trauma. Ligament, well, there's lots of small dorsal ligaments in the capsule on the back side of the wrist. So here I'm just going to show you, here we go, all these little ligaments here, intercarpal ligaments. Here's one going from the radius across to the ulnar side. So there's a lot of them. This doesn't even show probably but half of them. This is the posterior radial ulnar joint ligament right here. So those ligament issues can cause vague symptoms in the wrist and can be very challenging to diagnose. Ganglions are quite common in the wrist and hand, and on the dorsal side, about 50% of all asymptomatic adults with MRI, powerful MRI, shows ganglion, although they have no symptoms. On the volar side of the wrist, again, tenosynovial irritation. So they'll be actually swollen in the front of their wrist. Okay, and that may cause carpal tunnel syndrome because those structures go through the tunnel. Again, distal radial ulnar joint can be affected, and just like the dorsal side, there's lots of little ligaments. Here we go, lots of them between them. If we get disruption of a key ligament here, which you'll see later, that can lead to true instability at the wrist and lots of problems. Okay, clearly the median nerve is the key one. We'll talk about carpal tunnel syndrome a little later. That can cause volar wrist pain as well, and ganglions are common. On the radial side of the wrist, we have decurving tenosynovitis. We're just going to do this. Should be like that, decurving tenosynovitis. Synovitis means that the synovial sheath around the thumb extensor is what's giving them trouble. Also, the first carpal metacarpal joint at the base of the thumb is the primary osteoarthritis of the wrist. Okay, at that distal row into the carpal joint. We can get superficial nerve irritation, radial nerve irritation, and that's usually a proximal issue at the elbow. Okay, so the treatment is along from the elbow all the way to the wrist. And for ligament, there's really nothing specific over there. Of course, there are ligaments, but that's usually not a problem. And scaphoid fracture and osteonecrosis can occur. So here's an example of a scaphoid fracture here, and that's usually due to a fouche injury, which is a fall on outstretched hand. All right. Ulnar-sided wrist pain is a pain in the tailbone. It's hard to diagnose. There are lots of moving parts, and it takes some experience, practice, and maybe special knowledge to do a very good job with them. The primary problem from a musculotendinous standpoint is the extensor carpi ulnaris. That's the number one, remember that, it's the number one ulnar-sided tendon problem, extensor carpi ulnaris. And it's often due to overuse of the wrist and hand. I have one myself. I'll show it to you in class if you want to see it. The joint, the distal ulnar joint, can be associated with the triangular fibrocartilage complex, or the TFCC. You'll hear more about that in musculoskeletal. There's really nothing going on here as far as the nerve, because if there is a problem with the thoracic outlet syndrome or cubital tunnel or the cervical spine, it's not going to be local pain. It's going to be along the medial elbow and medial forearm into the wrist and hand. So there's nothing local that usually occurs there. It's usually a proximal issue. And the ligament, you can have overuse or trauma causing ulnar-sided carpal instability. I believe I have this, and I'll let you guys be the judge if you want to feel that tomorrow in class, what that feels like. And then we have that triangle fibrocartilage complex, often from overuse like a racket sport or golf or weightlifting or something of that nature. And then finally, this structure can be irritated and compressed if we have a distal radius fracture. So if you look at your wrist and hand with your palm up, imagine on the thumb side that you break your radius distally. If that shortens far enough, then what's going to happen is the ulna on the ulnar side of the hand is going to be longer than the radius on the radial side of the hand. That's a problem, because when the ulna is longer than the radius, it can compress this fibrocartilage complex and lead to degeneration and pain. So that's what we're talking about here. Distal radius fracture causing negative ulnar variance. And negative ulnar variance is the ulna being longer than the radius due to fracture of the radius. All right, dorsal hand, the tenosynovial issues we already talked about, swelling in the back of the hand. It's really not a problem with a joint in the back of the hand, unless there's trauma or rheumatoid arthritis or osteoarthritis. Nerve, can get radicular pain from above in what distribution? Is it C5, C6, C7, or C8? All right, there's really no ligament problem there unless, again, there's trauma and we can have ganglion in the hand. The volar side of the wrist, same thing. Tendon issues are usually traumatic, like a rupture or a laceration. The joint is usually, again, nothing without trauma or the arthritis. You can have radiating pain from the carpal tunnel, hand ganglia, trigger finger, which is when the finger gets stuck. We won't spend any time on that. And Dupuytren's contracture, which is a gradual loss of finger extensions. So they kind of come in and they end up with this claw hand. And sometimes that has to be released. It's a nasty little diagnosis. Okay, so pathology and exercise considerations. We're going to start with the elbow. First, we must inquire about the history of trauma or reuse. Particularly important for the elbow, wrist, and hand. Without trauma or reuse, we should really assume that they have a tendinopathy unless proven otherwise. Be aware the cervical spine can refer pain to the elbow, although it's not common. And I'll tell you a story about that in class. And of course, we should ask about neurotype symptoms, such as feelings of hot or cold, tingling. Any bizarre symptoms like that could lead us to think about the nervous system being involved. Okay, so let's start with tendinopathy. When we have a tendinopathy problem, particularly if it's a true tendinitis, we think about that maximal, moderate, protective phases and the associative exercises with them. Very straightforward, gets better quickly. All right. So in the maximum protective phase, usually is after a true overuse sort of syndrome. We want to keep it relatively still and quiet. We do active range of motion in the range that's comfortable. Setting exercises like isometrics. Most people that you see with elbow tendinopathy will be in the minimally protective phase. It's kind of vague, it's not terribly painful, it just limits them from doing what they want to do. So the main decision is, okay, is this a tendinitis, which is an inflammatory process, or is it tendinosis, which is a degenerative process of the tendon? And that decision making will help us decide what kind of exercise we should do. So is it tendinitis or is it tendinosis? Unfortunately, the clinical examination is not going to be helpful. So for example, if somebody has an overuse pain in the lateral elbow because they've kayaked or gone canoeing, and it's a week or two after, there's no way the clinical objective exam is going to help us decide if it's a true inflammatory or degenerative tendon process. The subjective exam, particularly chronicity, is what's going to help us. So, if it's been 6 weeks that the patient has been having lateral elbow pain and they've been able to really not overuse or abuse the elbow, we're talking about a tendinosis, right? Because tendinitis, the true inflammatory process, gets better fairly quickly within 2-3 weeks or so. So if it's been 8 weeks, 10 weeks, 3 months, 6 months, it's almost certainly degenerative tendinosis. So with a tendinitis, we follow the usual tissue healing exercise progression with range of motion, stretching, isometrics to concentrics to eccentrics, that process. With a tendinosis, particularly if it's in the minimal protective phase as far as their function goes, we want to stretch and progress them very quickly to eccentrics, because eccentrics have been shown to be the most helpful when dealing with non-inflammatory tendinopathy, which is, in fact, tendinosis. So the good research that's been done is for Achilles tendinopathy. So people that have tendinosis of the Achilles tendon doing eccentric loading have been shown to be far superior than the concentric exercises. And most folks feel that this can be applied to any tendinosis in the body. The other thing about tendinosis, it takes a great deal of patience This can take, guys, 8, 12, 14, 16 months to get better because the collagen turnover is very slow, where with a tendonitis, it's really about local inflammation, and that gets better pretty quickly. So it just takes time, and we need to inform our patients of that. All right, so moving on to elbow mimickers, cervical spine referred pain. What might give us a cue of that? Well, if there's a negative elbow exam, minus the palpation, because almost everyone's going to be tender there, there's really a negative elbow exam, no pain with range of motion, resisted tests, the joint feels normal, all those things, then we should think that the cervical spine is possibly contributing. The cervical spine may or may not, unfortunately, be positive. So you can do an exam on the neck and it may not show anything. And I'll tell you a story about that tomorrow. And then traction. So the treatment for that can be, if it's truly from the cervical spine disc, traction is helpful. Of course, postural and stabilization exercises proximally at the shoulder, like pectoralis stretching, scalene stretching, scapular exercises, deep neck flexor exercises, all those things that improve the health of the upper extremity through proper position and posture. Stretches generally associated, again, are the scalenes and pectorals, and we might use a nerve flossing program, which we'll talk about later. Okay, so mimickers can also include the joint. More commonly is a radiocapitellar joint, more than the humeral ulnar joint. Why is that? What did I say? The reason is because this joint is very stiff and congruent. So the more stable a joint is, the less likely it is to have arthritis, unless there's trauma. Over here, the radiocapitellar joint is quite mobile. Tend to have more issues over here. So what clues might we hear about that? Morning stiffness, subtle passive range of motion detection as far as an end feel difference. We've talked about that before. You've seen my wrist, how one goes better than the other. Objectively, we can use a pull test. I'll show it to you in class if you want to see it. That can differentiate the radiocapitellar joint from lateral epicondylopathy. And just be aware that joint compression at the radiocapitellar joint occurs with gripping. So when I squeeze something, I activate all my muscles up to the elbow, the extensors and the flexors, and I cause compression at that lateral radiocapitellar joint. Here, we want to stretch tight tissues, obviously, maybe the elbow and wrist flexors and extensors, and work on postural muscles, and strengthen the shoulder and the elbow, biceps, triceps, and everything around. Slow progression of gripping program. So if we have a radiocapitellar problem and that joint loads with gripping, we want to progressively increase that slowly. Putty is a nice way to do that because it's a nice objective measure of how much force you're using. If you're using yellow putty, it's very light. You can't really compress it that much and cause a lot of strain. But once we're up to blue or so, we're using a lot of strain to compress that putty. Advanced degeneration in either joint typically requires surgery. Okay, final joint lateral mimicker would be the radial nerve. So, what cues? Neuroscience and symptoms. And this is my favorite right here. Tenderness at the radial groove. What the heck is in the radial groove? Well, the radial nerve is in the radial groove as it wraps around the humerus. So folks that have tenderness there, I start to think about, maybe there's a little radial nerve irritation. That can occur without tendon problems or with tendon problems. So I always check it. And if there's truly an entrapment of the radial nerve, they'll have pain with resisted supination. So you can imagine holding your wrist in a neutral position, not supinated or pronated, in that neutral position, and turn the palm up against resistance. They're going to have pain in the lateral elbow because the radial nerve goes through the supinator. Postural education and corrective exercises are important. I want you to notice all these problems with the elbow, we want to think about what's going on proximally. And the reason is because the upper extremity functions best when we have a stable base of support. And those scapular exercises, pectoral stretching, all those things, very important. Make sure we are creating a stable platform for the elbow to work in. Okay, and clearly for, I should say not clearly, but for nerve-related issues, we want to use a nerve flossing program, and we will talk about that in class. Okay, moving on. Medial elbow mimickers. Again, signs and symptoms, tender in the cubital tunnel. So a little funny bone. We bang our tissue right behind the medial epicondyle. That's where the ulnar nerve runs, and that can cause tingling down the arm, right? And if we flex the elbow maximally and hold it there, people will have symptoms down their forearm. Those are signs of ulnar nerve compression. In that instance, we want to avoid end range flexion of the elbow, obviously, because that position decreases the space through which the ulnar nerve travels and increases the pressure on that structure as well. So here again, we're going to deal with pectoral and scaling stretching, make sure our scapular stabilizers are good, and then a general elbow program. All right, unusual mimicker, biceps bursitis. What the heck is that? Well, when we talk about the biceps tendon, you should know where the insertion is. So where is the insertion? Let's look at it. You should be answering this to yourself if you can. So origin is up here at the shoulder. Insertion here is on the radial tubercle, right, of the radius. I'm sorry, of the ulna. So you can see how when we are pronated here, the tendon becomes wrapped around the ulna. But when we're supinated here, you can see the bone on the edge, so it's free to move more easily. On the other side of this tendon is a bursa. Okay, so if I could remove the tendon here, on the other side of that is a bursa, like a wall here. On the other side of that wall is a bursa. So when we place our forearm in pronation, the bursa is what protects that tendon from rubbing against the ulna. Okay, so the important thing about that is that this can be diagnosed or differentiated from a biceps tendon because in a pronated position, if we have them do resisted elbow flexion this way, the biceps tendon compresses the bursa against the ulna. So if there's irritation to the bursa, it's going to be compressed with resisted elbow flexion here, but it won't be compressed here because it's free, right? It's not being compressed in supination, but it is in pronation. So in that instance, rest is the key until symptoms are under control. Then we do start a general range of motion strengthening program for the elbow. But bursitis usually requires rest, maybe sometimes a cortisone injection in rare instances. Okay, moving on to wrist and hand issues. Remember, it's important to recall if there's a history of trauma in the elbow, wrist, and hand. So without trauma, we should ask about history of activity. For me, lots of sports when I was a kid. So my ulnar wrist, I believe, has instability from playing golf, tennis, softball, baseball, ping pong, you name it, foosball. I did everything. So I probably have some subtle instabilities in the carpals, particularly on the ulnar side. So asking about past activity is important. Next, we want to consider if there are tendon issues, because these are the most common. These are the most common right here. Decurvanes, which is on the radial side by the thumb. We already said that. And the extensor carpal ulnaris, which we also said. Most common on the ulnar side. Then, after those two, we have the common flexor and extensor tendons of the fingers. So that's usually due to tenosynovitis. Not the tendon itself, but the structures that protect them. It's critical in this area to decide if it's the tendon or if it's the synovial sheath that's causing the problem. And we can test that out quite easily. Let's just go back there. So here's the key. When we're dealing with a tendon problem, the tendon is the issue. Loading the tendon will cause pain. However, if there's a synovial problem, synovial sheath around the tendon, then stretching that tendon will cause the problem. Okay? Load for the tendon, like an isometric test. Stretch for the synovium. So if people have a decurving tenosynovitis at the base of the thumb, okay, pretty common, doing a resisted test at thumb extension will not hurt, but taking the wrist and thumb into an ulnar position will hurt like crazy. Synovial, stretch. Tendon, load. All right. So, of course, we want to know when exercise won't help. So in the wrist, there are a couple of issues. Number one, cues of that is a big difference in dorsiflexion and volar flexion of the wrist. So if they can extend the wrist to 80 degrees but only flex it to 25 or 30, that's a huge difference. That's what we call a non-capsular pattern. We're going to talk a lot about this in kinesiology, okay, the capsular patterns of joints. And what that means is if there's a general capsular problem, in other words, just general stiffness, there's a particular pattern in which that stiffness takes place. This is a non-capsular pattern, where there's a big difference between flexing and extending the wrist. That tells us that there's some big problem, all right? And that's typically in the wrist going to be something like necrosis of the lunate or the scaphoid, or advanced instability. And I'll show you a picture of that in a little bit. With the ganglion, clearly exercises are not going to help a ganglion problem. I don't know what causes these. I'm not sure it's known at all. But there's no specific findings other than this. Big old fat cyst on the back of the hand, front of the hand, front of the wrist, back of the wrist, and so forth. Okay, so tendinopathy or tenosynovitis. We touched on this earlier. I want to show you this picture. The blue here, just make it a little bigger. The blue is the tenosynovium, okay? So people that have synovial irritation, this whole area is going to be swollen. This extends up here further too, guys. I don't know why they cut it off like this, but this blue should extend all the way up here like this. So people have swelling due to the covering of the tendon. Here's a tendon, nice white gleaming structure, and then surrounded by that synovial sheath. So, like we've already said, back up there, we've already said tendon issues are painful with isometric testing, tenosynovitis are painful with stretching. And the treatment with exercise depends on which. So, with tendon, we want to think again about that maximal moderate protective phase. We can start with isometrics, concentric, eccentric, and do general stretching. With synovitis, we're going to mostly rest it. Okay, that might mean some sort of a brace or a splint. They can do active range of motion. Isometrics aren't going to hurt at all, so they can do all the isometrics they want. But we want to do it in a mid-range. Why? Because putting it end range can stretch the tenosynovium, which is going to hurt. So, that being said, only stretch when symptoms are essentially resolved. Don't do it earlier. It's not going to help them. And again, like I said, bracing may be helpful in either of these cases when there's a symptomatic tendon or tenosynovitis issue at the wrist and hand. So, subtle instabilities. We talked about my ulnar right wrist. Okay, special tests can help find these. They're not easy to do without a great deal of practice. The other findings of the wrist are generally negative. In other words, range of motion is normal, strength is normal, but there's just a subtle sort of instability in the wrist, and often pain after we do activity. So strengthening the wrist, gripping, and I'll show you what hanging exercises mean and why that's helpful in class. Brace and a carpal stabilizer will often help these folks. Be very cautious of stretching of the wrist structures. Why do you think that is? Well, it's an instability. So if we take the wrist to end range and push on it, we may be causing problems with furthering the instability. I want to show you this picture. This is the most common instability of the wrist. Here's the radius, the ulna. Remember what I said? Radius is going to be longer than the ulna. That fibrocartilage is right here. So if you fracture the radius, it's going to foreshorten. This is going to be longer and it's going to compress on that tissue. Getting back to our instability, see this space here, that gap? Here's the scaphoid, here's the lunate, this is the hamate, okay? So the scapholunate instability can be caused from a fall and outstretched hands. That structure will rupture over time. This will spread wider and it'll start to affect other joints in the area as well. And eventually we get a big problem with function of the wrist. There we go. Moving on. So additional exercises, almost done with the lecture here. Additional exercises, tendon gliding exercises for the flexors are quite often used. You should just know about them anyway for any tendon issue in the hand as well as carpal tunnel. So here on the top left, in A, we have a hand fully open. B, we flex the distal and intermediate phalanxes. Here's a composite grip, complete grip. Here's a flexion only of the carpal metacarpal joints. And finally, flexion that does not have to do with the distal component. So I want you to think about what muscles are these primarily using, particularly this one and this one. What are the differences here? Think about that. Those are different. Those three. We're using them all here, pretty much. But what is the story with B, C, and E? We'll talk about it in class. All right, and then nerve gliding exercises. We're going to use those when we believe that we have a problem with nerve irritation peripherally in the upper extremity. So ULT1 deals with the median nerve, 2 with the radial nerve, and 3 with the ulnar nerve. So this is an example of, which one do you think? Her palm is up. What nerve goes on the anterior arm, elbow, and forearm? That would be the median nerve, ULTT1. Upper limb tension test 1. So this is a tension test. You can use those same testing positions to do gentle flossing or gliding exercises for those structures. Okay, just a couple of brief words on carpal tunnel syndrome. It's a syndrome, so it's not always easy to prove that it's going on. EMG, MRI, hard to pinpoint things sometimes. It's clinically easy to diagnose though. People have usually radial-sided hand pain, okay, that occurs at night, and if they shake their hands, called shaking hand test, if they shake their hands, they can often get rid of their symptoms. That's pretty common in carpal tunnel syndrome. What are the causes? Multifactorial, potentially. So double crush means that the nerve is being irritated not only at the wrist, but also approximately in the neck or thoracic outlet. Double crush meaning if there's compression in one place, it's going to cause another place along the line of that same nerve to be more vulnerable. That's double crush. We can also have synovial thickening of the flexor muscles of the fingers, and we can have lumbrical hypertrophy that can be a cause of carpal tunnel syndrome from distal, where the lumbricals are, to proximal. Okay, and finally, the lunate can sublux anteriorly and cause compression on the median nerve. Treatment is interesting. For the natural history of the disorder, people have mild symptoms tend to get a little worse, and people with severe symptoms tend to get a little better. So it's kind of this diagnosis as waxes and wanes over time. Surgeons often treat this, and it's generally helpful, although not always. So you can imagine if they go ahead and do that, but it's really due to double crush or a lunate subluxation, you can go ahead and cut it. Cut the ligament there in the front. It's probably not going to help them. So really, it's when folks have local problems that's pretty isolated that it helps the most. So here's our picture. Here's our carpal little bridge or tunnel here. You can see the tendons. Many of them go through there, 8 or 9, I think. And the median nerve sits right on top of that. Okay, last slide. There are many different protocols depending on the surgeon. And if you go ahead and go online quickly, like on a Google search engine or something like that, type in carpal tunnel surgical, post-surgical rehab protocol, and pull up a couple of them. You'll notice that generally they're different. And that's because the training of the surgeon is different. So probably not a lot in the research that tells us what is particularly helpful or not helpful. Because there's multifactorial reasons, surgery technique is different, so it makes it hard to study. Okay, folks, great. We'll see you tomorrow, and I hope you have a great day.